So if there's no any other questions, we can start with our next speaker, Professor Dr. Amit Thapa. He is Professor of Neurosurgery at Kathmandu University in Kathmandu Medical College Teaching Hospital and Chairman of Neuroscience Frontline Hospital at Kathmandu and past Head of Department of Neurosurgery at Kathmandu Medical College Teaching Hospital from 2014 to 2024. He is also Vice President of Nepal Epilepsy Society and also Vice President of Nepali Society of Neurosurgeons from 2021 to 2023 and Chairman of Neurospine Chapter of NISON from 2020 to 2022. Professor Amit, please, you can go ahead.
Thank you, Emil. And at the outset, let me thank the Yemeni Neurosurgical Society, as well as other partner associations who had come up with this third episode of third module of this comprehensive neuroanatomy educational program. And I have seen the program layout. It is really very interesting and very informative to the trainees as well as the junior doctors and even experts who have been doing things for the past many years, because revising particularly anatomical aspects is something which we always want to do. And in words of the famous neurosurgeon, Dr. Roten, whose images I was using for times and again, there is every time a new thing to read in neuroanatomy. With this word, I would like to start, and my work has been made very much easy by my previous speaker. And Dr. Nargiza had given a very good layout, a sort of a package in which she has already classified the neurovascular bundles at 3 positions, because this is something which we need to remember when we are attacking the brainstem and the cerebellum. So I have nothing to disclose. Most of the images which I have used in my presentations are actually the work of Dr. Roten himself, and also being taken from other 3D softwares which are available free on internet. And I will be citing their sources as I will go through. So why 3D dissection anatomy? Because it provides a unique learning opportunity. It gives us an spatial understanding. It gives you a virtual hands-on experience, because cadavers are very difficult to have a hands-on, particularly in scenarios where the body donation is not very common. So there the cadaveric exposures are very limited. And of course, when we try to integrate the anatomical knowledge with the clinical applications, it makes a lot of good knowledge about what we are dealing with. So in this presentation of mine, I will not only be using the 3D images taken from the cadaver, but also being using cartoons and the sketches to make the learning much more easy and comprehensible. So why this brainstem? What is so interesting about it? Well, when I was actually thinking about this, it came to mind that there are 3 functions which is very much interesting in brainstem, which is rather exclusive in this particular part of the brain. In fact, as brainstem only takes 2.6% of the total cardiac output, but then it does the function which no other part of the body, including the brain, can do. And the first and the foremost is the stem of the life. It actually regulates the heart rate, respiratory rate, and the blood pressure. It acts like a connecting place where it connects the cerebrum to the spine and the peripheral nervous system, and of course the cranial nerves. It houses the nuclei of the most cranial nerve from 3 to 12 nerves. So that's why it is the most interesting. And anatomically also, when we see that transition which is occurring from the brain to the spinal cord, in the brain we know that all the myelinated axons are inside and the gray matter lies on the surface. And when we see in the spine, it is just the reverse. The gray matter sits inside and the white matter is outside. So where does this transition occurs? From the CNS to the spinal cord, and that is the brainstem, where this all transition or the migration of the white matter to the gray matter occurs. And that's why this is very interesting area where we have to study as a neurosurgeons. So talking about the embryology, when we are 3 to 4 weeks old embryo, then the 3 brain vesicles, prosencephalon, mesencephalon, and rhombencephalon, they divide further. The prosencephalon makes the cerebrum and the thalamus, or the diencephalon. Mesencephalon continues to become the midbrain, and rhombencephalon divides into metencephalon, which makes the pons and the cerebellum. and myelin salon, that is medulla and oblongata. So if you see embryologically, both pons and cerebellum, they are derived from the Roman salon, and they are basically part and parcel of themselves. And that's why when we see anatomically, cerebellar hemispheres are actually wound around the pons. So that's why we see that the cerebellum is actually hugging the pons from both these sides, and that's how the relationship through the middle cerebral peduncle is too much intricate, and which I will be discussing in the further slides. So this particular structure tells the whole story of the infratentorial structures which we are talking about. So when we look from the top, the falx cerebri makes a tent, and this tent is, if you see, is basically a tent in a very geographical manner. So the center part is elevated, the anterior and the posterior parts are dipped down, and then there is a groove inside in which the cerebellar hemispheres and the brainstem sits between the occiput and the sphenoid, and as well as petrous bone on the sides. So this whole cavity houses the brainstem and the cerebellum, and they are connected to the middle fossa and the anterior fossa through the various nerves and the vessels, as we can speak about it. And then the other part of the story is that the aerated sinuses, the air sinuses, are lying anterior to the brainstem in form of a sphenoid air sinus, through which nowadays endoscopic approaches can be used to attack the midline structures of the brainstem from midbrain to the medulla. So this is something which is now being explored more often than the other classical skull-based approaches, which I will be discussing further. So when we see this particular structure called brainstem and the cerebellum, which is attached to the diencephalon and then to the cerebellum to the various tract, it has basically three surfaces, which Nargiza did mention about in her talk, and that is the petrosal surface, the petrosal surface and the ventral aspect. Then we have a suboccipital surface that is inferior, and then the other one is the tentorial surface, which is the superior surfaces. So the tentorium is actually separates the cerebrum from the cerebellum and the brainstem below. Now, looking from the back, this particular brainstem has a tactile plate in the back, which has basically four colliculi, two superior colliculi in the top, and then the two inferior colliculi below. And then it is separated by the pontomesencephalic fissure, from where the pons starts, and then the pons makes the upper the posterior part of the pons makes the upper half of the fourth floor, and then it has another fissure, which is the ponto medullary fissure, which actually makes the mark of the beginning of the medulla. The medulla again has two parts. The upper part of the medulla forms the lower half of the fourth ventricular floor, and then the lower part of the medulla actually finishes at the decussation of the pyramidal tracts. So this, in case you are looking at the cartoon, looks as that the thalamus is the bosom of a good-looking lady, and then the midbrain is the upper part of the trunk, and the pons and the medulla becomes the lower part. So the midbrain is the widest portion, and the medulla is the narrowest portion of the brainstem. Now, when we see the radiological pictures, the MRI pictures, it is very much interesting to remember it as a cartoon. So the midbrain actually appears like Mickey Donald, and the pons looks like a fat belly of a man, and medulla oblongata can be appreciated as a butterfly with the wings on. So these are very true characteristics of when we look at the cartoons representing these radiological pictures. And again, this is very important for us to remember, because any slight asymmetry in the presentations in the radiographic images of these structures can let you know that there is a degeneration of the neurons at that particular part. Now, cerebellum, I will not discuss this in further detail because Nargiza had already mentioned about it. But then just to add to it, this has basically a folial pattern, a leaf-like pattern, and it is divided into three lobes: anterior, posterior, and flocculonodular lobe by the primary fissure or the horizontal fissure, and then a posterolateral fissure is there. And beside this, we have 9 segments or 9 zones of the vermis, of which the uvula and the pyramids are the important ones to understand. And the vermis is something which we have already discussed about. So these are the different surfaces of the cerebellum, and this is something which is of embryological characteristics. So spinocerebellum, cerebrocerebellum, cerebrocerebellum or the hemispheres are the different parts which has been embryologically found for different components of the cerebellum and have been served to have different functions in humans. Beside this, we have four deep cerebellar nuclei, which actually creates a sort of an efferent and efferent receiver as well as an output creator. So dentate is the major efferent from where the cerebellar outputs actually goes out. So when we see this communication of the cerebrum to the cerebellum and to the midbrain, it makes an intricate connection between each. And the most important thing which the brainstem, as we have mentioned about in the function, is the cranial nerve nuclei. So most of the cranial nerves actually come out of the brainstem at various parts. And there's a rule of four, which is very easy to remember. So when we say the rule of four, that is the four cranial nerves actually arises above the bones, of which the two actually arises in the midbrain. So cranial nerve 1 and 2, they actually arise above, but then the 3 actually rises from the interpeduncular fossa. So these are the cranial nerve 3, which is coming out of the interpeduncular fossa of the midbrain. And the fourth nerve, the cranial nerve 4, actually arises from the back of the midbrain and it moves forward. It curves around the cerebellar peduncle on either sides. And then the pons is the site for the origination of the four cranial nerves. The one is the cranial nerve 5, which actually arises from the midpoint of the middle of the pons, and then the 6, 7, and 8 arises from the cerebellomedullary fissure. So if in case you can see, this is the cranial nerve 6 on the right side, cranial nerve 7 and 8 are arising from this particular cerebellopontine fissure. And then the last four, that is the cranial nerve 9, 10, 11, and 12, they will be arising from the medulla, of which the 12 will be arising from the pre-olivary sulcus, and then the 9, 10, and 11 arising from the post-olivary sulcus. So these projections on the ventral surface of the brainstem can be a very good navigating guide for all of us. Whenever we see these particular projections, we know that this is that structure which we're dealing with. So the cerebral medulla will have an anterior middle sulcus, which actually continues into the spinal cord and finishes as a depression at the cerebellomedullary fissure. So on the lateral aspect of this median fissure is the pyramid, and then on the lateral part is are the olives, and then we have these the peduncles on the other side. So when we see on the lateral aspect, it is the cerebellum, which is actually hung up with the pons through the peduncle. So the middle cerebral peduncle is the widest of all the cerebral peduncles, and it is a massive efferent to the cerebellum, which comes out of the pons. And the pons actually receives this communication from the cerebrum. So there is a cerebropontine fibers which actually goes into the pons, and from the pons it goes into the cerebellum through this middle cerebral peduncle. And again, this is important to understand that the trochlear nerve or the cranial nerve 4 arises below the inferior colliculi and actually goes anterior, winding across the crus cerebri. Now, these cranial nerves, when they come out of the brainstem, they go anterior or ventral, and then through the foramens inside the in the petrous bone, as well as on the lateral aspect of the clivus, they actually go into the middle fossa and then in the front, and then some of them can actually go out of the cranium. Let's say, for example, hypoglossal canal, they go directly out from the posterior fossa into the neck and below. However, cranial nerve 5, 3, and 4, and 6, they actually travel through the middle fossa, and then the 7 also goes through the temporal bone. So there will be a lot of traveling of these cranial nerve through the skull base, through which the most of the anatomy is explained. And these are also the sites through which we try to explore the brainstem from the front as well as from the lateral aspect. Now, coming to the vasculature, the vertebral artery, they join together to begin to make the basilar artery, and the basilar artery makes an impression over the pons also known as basilar impression over the pons ventral surface. And as you can see, the basilar artery actually goes and divides into posterior cerebral artery. The superior cerebral artery comes out at the second branches below, and then there is a superior cerebral arteries coming out, and then the ICA and the pica comes out below. So these are the different branches. As you can see, the superior cerebral arteries coming out, and then the ICA and the picas. And all these branches are important to understand because as the age grows, the vessels starts getting sacked, and then they actually come down. So as you can see in this picture, the SCA is actually dipping down and is trying to touch the cranial nerve 5 or the trigeminal nerve, leading to a condition known as trigeminal neuralgia and the patients with hemifacial spasms. Similarly, the SCAs can actually, the picas can actually go up and can also cause compression over the fifth nerve or over the seventh nerve, causing the hemifacial spasm in certain cases of neurovascular conflict. Now, regarding the vasculature of the midbrain, it is supplied by the posterior cerebral artery and its particular branches, the superior cerebral artery, posterior parietal artery, and interparietal branches of the basilar artery. Pons are supplied by the pontine arteries, anterior inferior cerebellar artery, and superior cerebellar artery. Medulla oblongata are supplied by spinal artery, posterior inferior cerebellar artery, anterior inferior cerebellar artery, and vertebral arteries. And cerebellum actually gets its vascular supply all from anterior through the superior cerebral artery, which supplies the superior part of the vermis and the superior surface of the cerebellum. The ICA, which supplies the cerebellar hemispheres laterally, and then the pica, which supplies the tonsils as well as the vermis below. So these are the different venous outflows. So the venous outflows can again be divided into three surfaces, as Nargiza did mention in our talk. So it can be superior cluster, anterior cluster, and the posterior cluster. So the superior cluster actually goes and drains into the vein of Galen formations, and then the anterior cluster actually goes into the petrous sinuses, through which it again goes into the transverse sinuses and the sigmoid sinuses, and then finds its way into the jugular veins. The posterior sinuses actually goes into the venous drainage, goes into the torcular heterophile, and then it comes out to the transverse sinus, to the to the sigmoid sinus, and later on into the jugular sinuses. So these are the three different clusters of the venous outflow. Now, when we look at the axial cut section of the midbrain, very interestingly, it appears that there are some impression known as substantia nigra, which actually gives a pigmentation marks on either side. And then there's a red nucleus. And then apart from that, everything looks very grayish. But underneath this all grayish structure, there are a lot of cranial nerve nuclei at different layer levels. And these are very much difficult to understand and very difficult to remember. So what we have found is if we can understand this basic concept of how these arrangements are done, then it can be actually replicated at all the levels of brainstem, be it midbrain, be it pons, or be it medulla. So the important thing is to understand that there are three layers of how these neurons and the axons are arranged in these part of the brain. So one is the basis. Basis is the ventral aspect. Tegmentum is the middle compartment, and the tectum is the superior, or is the most dorsal one. So tectum actually is present only in the midbrain, and it is deficient in the pons as well as in the medulla. Now, embryologically, if we see, compare it with the spinal cord development, then we can find that the floor, or the basal plate, is actually the motor nuclei, and then the roof or the ala is actually the sensory neurons, and they are connected through the ventral and the dorsal horns subsequently. So this arrangement is similar to the brainstem, but only difference is that the ventricular spaces actually get spread out and pushing the alar plates much more laterally and keeping the basal plate or the motor nuclei much more medially. And the separation between the alar and the basal plates are the sulcus limitans, which can still be present, can be seen on the floor of the fourth ventricle, as we will discuss in the future slides. So this arrangement is persistent throughout the midbrain, pons, and medulla. So keep in mind, all the motor neurons or the motor nuclei will be arranged medially to the sulcus limitans, and the sensory nuclei will be located outside these sulcus limitans. And other unique characteristic of this nuclear arrangement is the vertical arrangement of the brainstem nuclei. Again, the brainstem nuclei of specific modalities are arranged in the same vertical column. So, for example, the somatic motor nuclei, which are basically cranial nerve 3, oculomotor, the trochlea, as well as the abducens and the cranial nerve 12, they are arranged in the same vertical column, which is basically just in the midline. And if you can see, the 3 and 4 are lying in the midbrain. Pons has the 6th nerve, and the medulla has the 12th nerve. And then similarly, the brachial motor nuclei, which is now paramedian to the somatic motor nuclei, are arranged in the similar vertical column. So in this aspect, the midbrain does not have any brachial motor supply nuclei, but the pons has trigeminal motor and the facial nuclei, and medulla has nucleus ambiguous, which is basically the nuclei for cranial nerve 9 and 10. And then we have a visceral motor nuclei, which are basically for autonomic functions. So Edinger-Westphal nucleus lies in the midbrain, which is now lateral to the branchial motor nuclei, and followed by the superior salivary nucleus, which actually innervates the parotid and the lacrimal glands, which are found in the pons, and inferior salivary and dorsal vagal nuclei are there in the medulla. Now, inferior salivary nuclei, as you know, they innervate the sublingual and the submandibular glands, and the dorsal vagal nuclei is a major outflow for the vagal nerve and actually helps us for the autonomic functioning of our gut. So this north and south and east to west arrangement is seen throughout the midbrain, pons, and medulla. And this is very important for us to perceive, because this is where these are the areas where we have to keep in mind when we are attacking inside the midbrain, pons, and medulla, because these are the areas which will define the safe zone, safe entry zone, as we will discuss in further slides. So all the sensory nuclei lie outside the sulcus limitans. Now, midbrain, pons, and medulla, they are actually also serving as a connecting fibers or connecting tracks between the cerebellum and the spinal cord. So they will have descending motor pathways, ascending sensory pathways, and sensory peduncles, which will be communicating through each and other. So motor pathways are basically 3 in groups. So cortical spinal tract, they are very much laterally arranged in the cerebellum, in the cross cerebri, and then they continue further in the pons, and then it goes into the medulla. At the end towards the lower end of the medulla, it decussates and goes to the opposite side. So these are the pyramidal elevation which is seen on the medulla oblongata. The corticobulbar tracts are those tracts which arises from the motor cortex, but they finishes in the brainstem, and they actually serve the cranial nerve nuclei. So these are basically the communication between the brain to the cranial nerves. So they will be arranged medially to the corticospinal tracts, and the corticopontine fibers are the most medial ones. And so these are the ones which are actually communicating to the cerebellum through the pons, and that's why they are not there in the medulla. They will finish at the level of the pons itself. So these are the structures. So the midbrain, the projections which you can see ventrally are those motor fibers which you just talked about, the crus cerebri, the pyramidal, the pons, and then this is a pyramidal tract of the medulla oblongata. Now, when we talk of sensory pathways are actually lying inside the tegmentum area. And this has middle meniscus, which is basically nothing but the upward projection of the dorsal column. So they will be taking proprioception, fine touch, and vibration. A spinothalamic tract, they carry the crude touch, pain, and temperature. And lateral lemniscus is basically for the auditory pathway. So these medial lemniscus is a very important structure for us to understand, because they will be lying in the tegmental portion across the whole brainstem vertically, and they actually make the ventral portion of the floor of the cerebral aqueduct, as well as the fourth ventricular flow. And they are passed through by the middle cerebral peduncle. So we will be talking about those transactions. So when we see this simple layout, the basis of the basal plate is basically the motor pathways, tegmentum of the ulnar plate, which is the major component in the middle portion, is the ascending sensory pathways and the cranial nerve nuclei, and tectum, which is only present in the midbrain, which consists of the superior colliculi for the visual function, reflex function, and the inferior colliculi for the auditory reflex processing are there in the midbrain. Now, we talk about the cerebral peduncles because this is something which is the most important communication between the pons and between the brainstem and the cerebellum. So there are basically three cerebellar peduncles: superior cerebral peduncles, which is basically an efferent output from dental nucleus into the cortex. Middle cerebral peduncles are basically efferent pathways from cerebrum through the pons into the cerebellum, and inferior cerebral peduncles are efferents again from the spinal cord through the cerebellum, through the medulla oblongata into the cerebellum. So these cerebellar peduncles actually acts like a cerebellar loops, so as to keep the information flowing from the cerebrum when it goes into the spinal cord, and from the spinal cord when it goes to the cerebrum through the cerebellum. So it helps us the system to titrate itself for a good coordination of the movements, for reflex movement of the eyes, as well as for the turning the head whenever there is an audio cues to it. So all these movements are actually being served or fine-tuned by the cerebellum through these cerebellar peduncles. So this is how it looks like. So this is the superior cerebral peduncle, which is traversing through the midbrain into the cerebellum. And then you can see this is basically the efferent output from the dentate gyrus. So dentate gyrus actually takes all the communication from the cerebellum and then throws the efferent out through the cerebral peduncle, which decussates into the midbrain and then goes into the thalamus and above. And then this is the middle cerebral peduncle. So this is the middle cerebral peduncle, which is actually communicating the pons to the cerebellum. And you can see this is the major pathway. So the pons is actually hugging the cerebellum through the middle cerebral peduncle, and these are the largest fibers, as we just mentioned it. So this is a portion of the inferior cerebral peduncle. So from the spinal cord, it goes through the medulla oblongata into the cerebellum, and this is basically an efferent pathway taking the sensation from the spinal cord into the cerebellum. So this is again a pathway which is shown through the floccular nodular lobe. So there was a question regarding the role of tonsils. So the floccular nodular lobe together with the tonsils actually help to have the reflex movement of the eyes. So visual gaze fixations are done through these particular through these pathways. Now, this is again a coronal section which shows that the superior peduncle actually forms the wall of the upper part of the fourth ventricle, and the inferior cerebral peduncle actually makes the wall of the inferior portion or the lower portion of the fourth ventricle. So this is the facial colliculus. So this is the abducens nucleus, and then you can see the facial nerve on the either side, and this is the dorsal medial sulcus. So we'll be discussing it further. So you can actually have an idea of the cerebral peduncles on the MRI itself. So this is the superior cerebral peduncle as seen in the midsection of the pons. The lower pons shows the middle cerebral peduncle. The most difficult to identify is the lower cerebral peduncles, which are very fine and sometimes can be very easily missed and can be picked up on the pontomedullary junction. So white matter tract, as we've already mentioned, there are many tracts which are going up and down the whole thing. And then if you think that this is still confusing, the most other thing is the reticular formation, which we all know are the diffuse group of the neurons within the medulla oblongata and the pons. And they actually serve the function of consciousness, wakefulness, and alertness. And they have two pathways, ascending reticular activating pathways and descending reticular systems. So they have respiratory and cardiovascular centers, which regulates the breathing and the heart rate, and they participates in activating the brain so as to give the form of a consciousness and wakefulness. So various hypotheses, or rather tracks, are hypothesized that these are existing, including the periaqueductal gray raphe and medial lemniscus, which actually goes and projects into the sensory cortexes through the thalamus, striatum, and in middle prefrontal cortexes, and many more, hypothalamus, which activates the memory, emotion, sleep, and reward systems. So these are various tracks which have been found to be flowing through the brainstem so as to give us wakefulness. Now coming to the CSF pathway. So brainstem is connected inside through the to the CSF pathway. So cerebral aqueduct connects the third ventricle to the fourth ventricle, and then the CSF flows out through into the central canal or the foramen of Morgan-Magenti out into the subarachnoid spaces, or to the lateral recesses through the foramen of Luschkas on either side into the cerebellopontine cisterns. So this is how it appears that the CSF spaces between the brainstem and the cerebellum through the roof of the fourth floor. Now, the floor of the fourth ventricle is also very unique because, as we have mentioned, it is bounded on the either side by the superior cerebral peduncle and the inferior cerebral peduncle. On the floor, it is actually marked by the dorsal median sulcus, and on just lateral to it will be the cranial of 3, 4, 6, and 12, as we have just mentioned about it. So the most important projection which is seen here are basically the branchial motor of the seventh nerve. So subfacial colliculus is seen here. And then this is the stria medullaris, which actually divides the fourth ventricular flow into the pons above and the medulla below. So you can see this is the facial colliculus, and below it will be the hypoglossal triangle. And then below it is the vagal triangle, and then again below it is the area postrema. So this area is also known as calamus sceptivorus, that is that nip of the pen, the pen nip. And then you can also have the cochlear nodule on the either sides. So these are very important structures to be able to be visualized on the fourth ventricle, and that's why I've kept a cartoon on the side so as to help you to identify it much better. Now, how to attack the lesions inside the brainstem actually depends upon where the lesions are. Is it in the midbrain, pons, medulla, and cerebellum? And correspondingly, we decide on anterior approaches, lateral approaches, and posterior approaches. So when we say of anterior approaches, it can be from orbitozygomatic approach, or it can be subtemporal approach, or it can even be a transcavernous approach, depending upon whether we are trying to hit on the medulla, or sorry, midbrain, or we are going a little further down into the pons where we require a sort of an anterior petrosectomy to reach the pons. And then the medulla can be attacked either from the transclaval approach anteriorly, or it can be done through the retrosigmoid or labyrinthine approaches or transcochlear approaches from the lateral sides. The dorsal surfaces are attacked from the suboccipital routes, either infratentorial or supratentorial. So there are many methods to do about it. And then when we see the ventral surface of the brainstem, so these are the different combinations we were talking about. So when we are trying to attack any lesion which is there in the midbrain, so one can come through the frontozygomatic route and then cut open the tent to reach the midbrain, or other person can try a middle fossa approach to the subtemporal route and then can do an anterior petrosectomy to go on to the upper part of the pons. And then if in case we are trying to look at the lateral surfaces, there's a CP angle, then we can go through the retrosigmoid approach, or we can add a translab or a transcochlear approaches to go much more medially through the same route. And then far lateral approaches can give an access to the anterior surface of the medulla oblongata. And beyond this, nowadays we are having an nasal approaches through which one can access from the midbrain to the foramen magnum through the transclaval approaches. So this whole thing can be opened up from the anterior, from the front, from the lateral as the need arises. So this is a cartoon to show that the clivus is the main factor which actually hides the pons behind. So one can reach the midbrain from the top, or do an anterior petrosectomy to attack the upper part of the pons. However, to reach the medulla and the pons from the front, either you have to do a transclaval or go from the lateral approaches. And then from the back, it is either infratentorial or supratentorial approaches. So supratentorial approaches can hit on the pineal gland, superior colliculus. However, if you have to reach the inferior colliculi or to the trochlear nerve, then you have to go through that tent itself, because the mid part of the cerebellum cannot be pushed down. So you have to come from the paramedian approaches. And then the suboccipital route and the far lateral approaches can let you open the fourth ventricular floor as well as the late recesses. So there is a modification known as telovelar approaches, which can open up the whole floor of the fourth ventricle. So this is a pictogram to show how we can attack the posterior part of the midbrain through the trans-occipital approaches, trans-tentorial approaches, as well as infratentorial supracerebral approaches. So this is a picture to show how it looks like when we are coming down from the underneath the tent. So one anatomical fact one should be aware of, that between the bregma and between the lambdoid and the external occipital protuberance, the 5 centimeter, the last 5 centimeter does not have any bridging veins. So that's why you can easily retract the occipital lobe and can actually attack the pineal gland and the superior colliculi from the top. So this is how it appears when we cut off the tentorium. So you can see after lifting that occipital lobe, you can actually have a good view of the pineal gland and the superior and the inferior colliculi and the cerebellum beneath. So this is how it appears. So this is the pineal gland, and this is that look into the third ventricle, superior colliculus, inferior colliculus. This is the trochlear nerve coming out inferior collicularly, and then this is the part of the superior peduncle. So this is the superior surface of the cerebellum. So this is a small operative video of an endoscopically conducted surgery where we have removed the pineal gland epidermoid cyst. So after sacrificing the precentral cerebellar vein, the whole cerebellum can be actually pushed down, and then we can have a good access of the tumor. And so just for the sake of time, I'm trying to move that further. So you can remove the whole tumor very fast. You remove the capsule of the tumor, and then you have a look completely inside with a 30-degree scope and to confirm that the tumor has been completely removed. So midline suboccipital craniotomy is another approach to the dorsal surface of the brainstem as well as the cerebellum. So after exposing the vermis and the occiput, nowadays we do not do a vermian resection because it has been associated with the mutism syndrome. So we retract the cerebellar tonsils. So when we retract the cerebral tonsils, the structure which is in front of us is the inferior medullary velum in the top and the choroidal tela choroidi in the bottom. So when you open it up, then we can actually have the whole look of the fourth ventricular floor. This is the cerebral aqueduct. One can peep into it. And you can even go superiorly into the lateral recesses by removing the superior medullary velum, like as in this case. So one can go into the dorsal cochlear nuclei, even to the lateral recesses here by cutting through the superior medullary velum. And then the whole floor is in front of us. The point to note is whenever we are trying to do that, just lateral to the vermis, to the uvula, this is the tonsil. So this is the structure which is known as dentate gyrus. So the dentist gyrus should not be injured by a retractor or by your haze of removing the tumor or even during the coagulation, because that can cause mutism in the patient. So when the fourth ventricular floor is opened in front of you, the most attractive or the most prominent feature which immediately gets into your eyes is the facial folliculus, which is basically the obtuse nucleus, and then the facial cranial, the facial nerve going around it. And then there's trimedullaris, and then there's a hypoglossal triangle, and then there's a vagal triangle below. So this is the case of a medulloblastoma. So you can see the pre-op images here. So this was a kid. So this patient presented with gait ataxia and headache because of the hydrocephalus. So we removed the tumor in toto completely, and then you can see the post-op, the patient had a very good outcome. The tumor was completely removed, and he is now a 15-year-old kid and doing well without any features of recurrences because of the complete resection in the first part. So this is another case of a dorsal pontine glioma, as you can see here. So this can also be approached in the similar manner. Coming to the lateral approaches can be retrosigmoid, transmastoid, and can even be combined as a combined supra and infratentorial if in case we can approach it through the pre-sigmoid extension. So idea is to find out through a craniometric point. So the asterion actually makes a junction which you can identify the junction of the sigmoid to the transverse sinus. And this usually lies in just above the mastoid groove at the level of the zygoma when you are projected backward. So once you are going into it, you can be retrosigmoid in most of the cases. If you want to go pre-sigmoid, then you have to cut through this bone and then you have to expose the jugular vein correspondingly. And then this is how it is being done. So after exposing the muscle, we actually look for the asterion and then we do a crinotomy and then we raise it. So the whole CP angle looks in front of it. The first portion of the cerebellum, which actually greets you once you open through a crinotomy, is the flocculus. So the moment you raise the flocculus, the seventh and the eighth nerve comes into picture. And then you can even identify the sixth nerve in the front, and then the fifth nerve on the top, and then the ninth and complexes, and then the 12th nerve correspondingly can be identified. And then once you have a tumor, the tumor will not be allowing you to see all this normal anatomy. So you have to be careful in this, that try not to search for the anatomy there, try to remove the tumor by decompressing it, and then look for the anatomy through the arachnoid membrane. So sometimes it is very difficult to identify the origin of the seventh nerve. So the most important anatomical guide which you can take is to try to look for the origin of the ninth and 10th nerve. And if you draw a straight line above, you will hit on the origin of the seventh nerve. So this is a very good view to look at the origin of the seventh nerve. And then this is the flocculus. So this is the arachnoid granules which are coming out from the lateral fissure. And then this is the ICA, which is seen here. And then the point to note here is whenever we are retracting the the flocculus behind, try to visualize any veins which are stretched out, because these veins get teared very easily. And while trying to hold the bleeding, you end up injuring the ninth and the 10th nerve, and the patient will have a loss of a gag reflex in the postoperative period. So try to coagulate and cut these stretched out veins before it bleeds, before to have a good surgical output. Similarly, internal acoustic drilling is another important part, particularly for cases where the patient is having a vestibular schwannoma. So you drill the lateral portion of the auditory meatus, and then we expose the superior and the inferior vestibular nerve as shown here. So this is the this is the facial nerve. This is the nervus intermedius, and then the cochlear nervus is underneath there. And then this is the ICA, and this is the subarachnoid arteries. So there's a Bill's bar which actually separates the superior vestibular and the inferior vestibular nerve. And then there is a horizontal crest, and then this is the internal acoustic meatus. So when we open up the internal carotid petrous branch of the portion of the internal carotid artery, so this can also be exposed from the back. So this is just in the cadaver. So this is a quick video of how we done an acoustic schwannoma with a perfect functional preservation in the patient, so pre-op and post-op. For the sake of time, I'm just jumping around this in this video, but then you have to identify the anatomy at the last. Try to keep the arachnoid preserved as much as possible so as to have a good functional preservation. Similarly, this approach can also be used to remove the cavernomas, as in this case with a recurrent cavernoma bleed presenting in the pons. So this patient was approached to retrosigmoid route, and you can see even after 1 year, the patient had a good output, and there is no recurrence of bleed in the last 10 years of the follow-up. So another approach is the retrolabyrinthine approaches, which is actually pre-sigmoid approaches. So this is the sigmoid vein. So you go anterior to it, and then you open up the dura from here, and then you can attack the much more medial portion of the ventral aspect of the brainstem from these routes. Subtemporal approaches is used to attack the midbrain. So this is the 10th you can see here. So this is the third nerve, this is the fourth nerve. So you open up the 10th here, and then you can see the cerebellum and the pons and the midbrain and the pons junction on this part. And then this is the portion of the fifth nerve, which is still seen underneath the dura. So one can even attack this particular part. And then if in case you are going through an anterior petrosectomy route, so you have to go on and expose the fifth nerve roots, and then you have to open up the anterior petrous and then drill the anterior petrous, trying to preserve the cochlea at all costs so as to maintain the hearing. And then you have a good access to the midbrain and the pons. So, and then nowadays the intranasal approaches are there, which can give you good access from the ventral, from the top to the bottom, as we have discussed. And then even the midbrain can be attacked through a transfemoral route by doing a pituitary translocation. So this was a case of an hypothalamic hematoma, which was attacked endoscopically using this method. Now, how do we decide? So this was up till now we have been discussing about how to reach the surface of the brainstem. But then how to go inside the brainstem and how to decide it, that's another question which you all need to answer. And a very good publication by Spessler group had been a two-point method in which you connect the center of the lesion to the outer edge of the lesion, which is connecting to the surface of the brainstem. So the whole idea is to identify approach where we do not go through the normal brainstem tissue. So try to connect to the tumor tissue as early as possible, either through a pile or ependymal surface. So by which you can identify, like in this case, even though this is abutting the fourth ventricular flow, since this tumor is lying very close to the surface, the best approach would be a suboccipital approach here. And then in this case, that the tumor is abutting on the lateral aspect. So the most good method would be a far lateral approaches. Now, a brief word about the safe entry zone, even though there is nothing safe as such inside the brainstem, because we have just mentioned and discussed about a lot of things which are compacted into a very small structures like a brainstem. Still, because of the layout of these cranial nerve nuclei and the corticospinal tract, we know which areas are still a little bit giving you a space for some mobilization. So these safe entry zones can be found in the anterior mesencephalic area or in the lateral mesencephalic zone or in the posterior mesencephalic zone in the midbrain. In the pons, it is very difficult. It is only arising in the supratrigeminal or the peritrigeminal entry zone areas, and in the medulla, they are in the anterior lateral sulcus or in the lateral medulla or in the fourth or from the floor of the fourth ventricle. So one by one, so when we go through it, so in the midbrain, it is the lateral mesencephalic sulcus. So as you can see from the lateral aspect, so this can attack the tumor from the front as well as which is extending into the back. So this is how we can approach the lateral mesencephalic sulcus, either through a middle fossa approach or through a subtemporal approach. So we can go and can cut the tent, and then the whole thing is in front of us. Then we have to be cognizant of this fact that the angle of the entry through the lateral mesencephalic approach should be almost 90 degrees to the surface, because if we are much more acute, then we'll be hitting on to the red nucleus, and if we are much more obtuse, then we'll be going towards the corticospinal tract or the substantia nigra. Then the other safe entry zone is the supra and the infra collicular areas. So this is also superior or inferior to the colliculus or the tectal plates, which can be attacked from the back. So this can be from the supra or the infratentorial areas, and this is how it appears whenever you're going in infratentorial supracerebral approaches. So this is how the incision is given, and then you can actually go inside and remove the tumor safely. The other area is the other safe corridor is the periocular motor zone. So this is in the interpeduncular fossa. So this is how it appears like when you attack it from the front. So this is the basilar artery. This is the superior cerebral PCA and the SCA. And between the SCA and the PCA, you can see the oculomotor area nerve coming out. So this is the area, the perioculomotor area through which you can go inside and can remove the tumor or the pathology safely from the front. The other safe entry zone for the pons is the peritrigeminal zone. So this is the fifth nerve, and this is the seventh nerve. So between the fifth and the seventh nerve is the peritrigeminal zone ventrally, through which one can remove this particular lesion, and this can be approached either through a retrolab approach or a retrosigmoid approaches to approach this particular area. And even through the middle fossa approach, one can do an anterior petrosectomy and can reach up to this area. Then the other safe entry zones for the dorsally lying lesions is from the fourth ventricular flow. Even though this is mentioned, this is a very difficult area to attack because of a lot of motor nuclei lying around. So one have to be cognizant of the facial colliculus, as we have mentioned about it. So the safe entry zone here would be a suprafacial approach or an infrafacial approach, or it can be through an acoustic area, which is located on the lateral aspect, or through a medial sulcus, which is above the facial colliculus. Mind you, there will still be some cranial nerves like because the cranial nerve 3 and 4 are lying in the midbrain. This area is something which does not have any significant motor nerve area. But again, this is a very small area to go through, and this is good for only very small lesions. And then in the medulla, there can be, and posteriorly, you can attack through the dorsal medullary sulcus. So this is how it appears on the fiber dissection methods. And then in this the medulla, you can have the post olivary sulcus and the anterior olivary sulcus. So these are the two other areas which is considered to be a safe entry zone. And then to help with this are the INM monitoring devices, which can help you to map the cranial nuclei, and navigation is also supposed to be a good adjunct to these surgeries. And nowadays, the navigation is being done even with the help of the robot. And the fluorescence imaging comes very handy in these cases to identify the vessels and the tumor around. So to conclude, infratentorial structures, they require a unique perspective because of its unique properties and its location and the way it is layout in structures. And that's why understanding the embryological development and the layout is the key to the safe surgery. And if we can understand the lesion and the surrounding key structures, we can keep the patient safe throughout the surgical journey. I would like to welcome the trainees to our center, which is a WFNS Foundation Postgraduate Training Center, a Kathmandu Medical College at Kathmandu. We support you for short training and stays here. And we also like to invite you all from behalf of the Nepali Society of Neurosurgeons to the 5th International Conference of NESON. This will be taking place from 13th to 15th November in the city of Kathmandu. You all are most welcome. Thank you for your patience listening, and I will be happy to answer any query.
Thank you very much, Professor Amit. And I would like to welcome Dr. Riaz Ahmad Raja, President of Pakistan Society of Neurosurgeons, and see what is the word about this fine and fantastic presentations. Dr. Riaz, please unmute.
Thank you so much, Dr. Ahmed, and welcome all in this Neuroanatomy new webinar. It started from the 4th July. I'm very happy that you all have joined for this cause, and this is a really good cause for the new and newcomers of the, particularly the students, residents, and also the young neurosurgeons to know about the proper neuroanatomy for the proper neurosurgical cases. I'm very glad that Dr. Amit has presented a very nice topic and very precisely and informatively presented his topic. So thank you so much all, and we will continue these lectures in subsequent months also. And I wish these type of the activities, academic activities, will provide a better platform for the young neurosurgeons. Thank you so much.
Thank you very much, Professor. And I would like to take the opportunity to give my thanks and gratitude by the name of the Yemeni Neurosurgical Society to Dr. Amit and Thapa and Dr. Nargiza for participating and supporting our activities, as they also supported in Module 1 and Module 2. And also, inshallah, they will participate with us in future modules. And they gave very nice presentations and very nice comprehensive overview of the subject that we would like to give in Module 3. And that will be discussed in more details in future presentations in further weeks, inshallah. Dr. Najida already met in person last November at Cairo at the WFNS conference, and she's a very brilliant and very active neurosurgeon, and he's very kind and very nice neurosurgeon. And Dr. Amit, I didn't meet in person, but I have much contact with him, and he participated with us in Yemeni Neurosurgical Conference, and also in Module 1, Module 2, and now in Module 3. And he's one has always very nice and very comprehensive presentations And today presentations are a very good start for our module. And also I would like to give my gratitude to Dr. Riyad Ahmed Basha, Raja, President of Pakistan Society of Neurosurgery, and also for Dr. Salman Sharif, coordinator of WFNS committee, and Dr. Abu Dhar Gangoor, head of Young Neurosurgery Forum, and Dr. Ayub Cherian, the founder of Neurosurgical Couch, for their support and collaboration with the Yemeni Neurosurgical Society to support this initiative and this presentations. So thank you, Professor Amit, thanks you, Professor Riyad, and thanks you also, Dr. Nargiza, for your support and for your help for our initiative. Okay.
Thank you.
Thank you so much. Thank you so much for the presentation, Dr. Amit. It was brilliant. If you don't mind, I want to ask one question.
Yeah,
Could you
please.
give small comment about trans-oral approach? Have you ever, do you perform them? Or I know it's like old school fashion, but sometimes some tumors who are growing, they are unavoidable in that approach. And what is your opinion about that?
Yeah, we used to do it. We used to do transoral approaches still. I think the last time when I did was in 2014, and after that we have completely transformed into an endoscopic approaches, both nasal and transoral. In fact, endoscopic approaches have a lot of benefit over the classical transoral approaches where we do a maxillotomy to gain an access. First is that it is not destructive. Second is, since you have an endoscope inside the field, you have a wide vision inside. So with a good illumination, you can see the edges. And with the good gadgets like the navigations coming up, you can actually have an idea about where you are inside. So chances of getting misplaced inside the cavity is very, very less. And of course, as Dr. Rotten would say, the best navigation is always the good anatomical knowledge. So if you have a good microsurgical knowledge of what you are doing and where you are landed, then chances of getting missed out is very, very less. And then having said this, nowadays with the neuromonitoring gadgets which we have, we can even map the area so you can have an idea that you are not harming the patient anytime because of your access or because of your procedures. So endoscopic approaches are something which we should all learn to do, and endoscopic endonasal approaches, endoscopic or transoral approaches are now gaining a lot of momentum, and we can access from the top to the bottom of the brain.
Thank you so much.
Very much, Professor Riyad. Professor Riyad, are you still with us? Okay, I will ask the audience if anyone has any more comment and question for Professor Amit Thapa. Otherwise, we can conclude this session, inshallah. So I don't see any questions. So thank you very much, Professor Amit, and thank you very much, Dr. Nargiza, for this good start and very nice presentations. And I will ask Professor Riyad Ahmed Raja, President of Pakistan Society of Neurosurgery, to give his concluding remarks and concluding words for our first session of Module 3. Professor Riyad?
I'm mute.
Yes, sir.
Yeah, no, we can hear you
Yes.
now.
No, you're audible now.
Now you can hear me. Okay. So it is concluded that all the topics are well selected by Yemeni Society, and Dr. Ahmed was the initiative, and he also proposed Pakistan Society and given the presenters for the presentations. Many topics in future we will see the better will be presented. And I would also request Dr. Amit to send me your Congress poster, and I was looking that, but there was just a little bit of hindrance, so I couldn't find when it is going to be happen and which type of the conference in Nepal. Because 3 years back, I was also arranging the conference in the Pakistan, so I couldn't come to the Nepal. So I love to come in Nepal if you'll invite me.
Oh, of course, you're most welcome, sir. In fact, this is from 13th to 15th of November. 13th to
Okay.
15th of
Oh,
November,
again
2025.
there is a problem, because in these days the Pakistan Society of Neurosurgeons annual meeting is organized already. These are the days which we are booked for the society's annual
Oh.
meeting.
In fact, November is the best time to visit in Nepal. In fact, Nepal is it's good to visit any time, but then November is the best to see the mountains and to go for
But
hiking.
next time I think we will already will discuss about the date, so that the Nepalese people should come to the Pakistan and the Pakistani people should visit to the Nepal. So
Yeah, that would be
we
extremely
want
good.
to, yeah. Thank you. And thank you so much, all of you, Dr. Nargiza, and
Thank you so much, sir.
very nice to see you. And
Okay.
I'm thankful to all the residents who joined this webinar, and thank you so much for all of you. Thank you.
Thank you.
Thank you, Dr.
very
Ahmed.
much. Thank you very much, Professor.
Oh, okay.
Thank you, Dr. Ahmad, for your organization also.
Thank you very much.
Hardworking.
Thank you very much. So by this we can conclude our first webinar of day 3 of a comprehensive neuroanatomy education program, and I hope we can see you all next week, next Friday, inshallah, with more presentations and more speakers, inshallah. So thank you everyone, and see you all
Have a nice
next
week.
week,
Bye-bye.
inshallah.
Thank you.
Bye-bye.
So,